All right, I'm Eric Cotter, a sports medicine surgeon here at the University of Wisconsin. Today we're going to be going through the physical examination of the shoulder. We have Colin here who's graciously agreed to be our patient. We're going to start first by talking about a few general points to a good physical exam. And one is exposing the area you want to examine. So for men, having them take their shirt off. If it's a female patient, getting them a gown, ideally having like a cami or a tank top on, so you can see not only the shoulder region anteriorly, but the scapulothoracic articulation posteriorly. So for Colin, we have a shirt off here, and we're going to start with inspection. So we'll examine his right shoulder here first. You want to look for any previous surgical scars, any deformities, abnormalities to them, and you also will have you turn here, Colin. You want to look from the back too. At the contour is posture. I found this more particularly in men, become pec dominant. They can have this protracted scapular rolled forward shoulder. So taking a look at posture is really helpful. And then the cervical spine plays in a lot with shoulder pathology. So seeing if people have any significant kyphosis where they're kind of hunched forward or lordosis to their cervical spine is really critical. So after we do inspection to evaluate for any previous surgeries or abnormalities, we'll start with palpation. And when I do palpation, there's really three spots I typically hit. The first is the AC joint. So your clavicle comes over here and it meets the acromion at your AC joint. It's pretty prominent on most folks. So in people that generally weightlifters in the younger patient population can have a hypertrophic or osteolytic AC joint that can be painful. And then as we get older, it's very common to have osteoarthritis of your AC joint, so it can be more prominent and painful. So I always palpate here. And then the bicipital groove, so coming in at where the pectoralis comes over in your deltoid running down here, that deltopectoral interval, you can rub in here and you can actually run over the biceps here. So those are two areas I always palpate, and then I'll have you turn one more time. Another area I frequently palpate is just medial to the scapular, the medial border of the scapula in here. This can cause some crepitus and can be painful in some folks. I found it really hard people talk about palpating for cuff tears at the greater tuberosity where 3 of your 4 cuff tendons insert. I've never found that to be overly helpful, but if you were to do that just off the acromion on the side here, again, I haven't found that to be markedly fruitful. So once we're done we've done inspection, we've done palpation. Next, I check range of motion. So I stand in front of the patient. Colin will have you go up in front of you in forward elevation as best you can. So he goes all the way up, and you can see he gets up to about 180 degrees. And the nice thing about the examination of the shoulder is you have 2 of them. So you can always look at the injured shoulder and then the uninjured shoulder, and you have something to compare to. Come on down. I'll have you turn, Colin. One other thing I always look for too, as we're examining range of motion, some people have some physiologic winging. You can also have pathologic winging of your scapula. So I'll have Colin raise his arms up here. So you can see his scapula stays really nice on the chest wall. Come on down, Colin. Winging is defined as where the supramedial border of the scapula turns. So people can medially wing where it kind of goes like this and your scapula tips up like this, or lateral where it goes vice versa. And again, we see that a lot in overhead throwers, volleyball athletes, get some physiologic wing. There can also be some pathologic wing when people have nerve type injuries. So after we check forward elevation, come face me again, Colin. We'll have you do abduction out to the side. Yeah, beautiful. Colin's got wonderful range of motion. Come all the way up, symmetric. Come on down. Have you come in like this. Keep your elbows adducted, open up like a book. So this is external rotation 1. We call this ER1. So he can get out here, beautifully to about 80 on both sides. ER2 is when we come up in the abducted position to 90, and then where do we get? And in overhead throwers, it's not uncommon to get more external rotation in the throwing arm, and they have a little more of an internal rotation deficit. Colin's a very flexible person, so he is pretty symmetric, but we call this ER2. All right, come on down. And then we'll have you turn for the camera here. Can you bring your thumbs up your back? This is my favorite way to check internal rotation. So in general, the inferior border of the scapula is about T7. That's a rough estimate. You can always count down the vertebrae, but I usually mark this at T7. So he has pretty symmetric internal rotation bilaterally. All right, now we've done inspection, palpation, and general range of motion of the shoulder. It is best practice to check range of motion of the cervical spine. So I generally will have patients flex and extend. You want to go up and down, Colin? Yeah, he's got no issues here. And then rotation side to side. This comes into play more when we're looking at patients that may be a little bit older with arthritis. We're thinking about doing a shoulder replacement. Some of those folks have arthritis of the neck, which can limit motion and play into things. For Colin, that's no problem. Now we're going to move on to special tests. There's a number of tests in the shoulder for things like rotator cuff pathology, labral injuries, biceps. So we're going to start with cuff. This is kind of my normal sequence. So a variation of the empty can test. We call this the full can test, or as a mentor of mine taught me, the champagne toast. So like you're given a champagne toast in the scapular plane, so forward elevated out about 30 degrees. So having your thumbs up is more of an anterior supraspinatus test. We have Colin hold up here against resistance. Try to push down, very sturdy. Now if you go down, thumbs down, empty can test or champagne pour. This gets more of that posterior supraspinatus, that supra-infra junction. Hold up here, Colin. Yeah, very strong. Now we'll have you come down, elbows in at your side. I want you to push out against me. This is testing your infraspinatus. Yeah, very strong. Now there's a number of tests. So that's ER1, so infraspinatus. ER2 would be hornblower. So up, we're in ER2 now, external rotation 2. Don't let me push down on you, Colin. So that's teres. As you come up into the more adducted position, you can get your teres minor in the back. So that's called a hornblower's test. Not something I use a lot of, but in patients that have massive cuff tears, teres is oftentimes the last muscle on. It's nice to know if that's still giving you any external rotation strength. For subscapularis or internal rotation strength, the two main tests I use are the belly press and then the bear hug. The belly press is pretty good at getting the upper border of your subscapularis, whereas the bear hug is a little bit better for that lower third of your subscapularis. So we'll demonstrate first the belly press. So I've Colin put his hand on his belly and keep his elbow out, and then I'm going to try to pull him off. So try to resist me here. He's very strong. So when people have a positive belly press, what generally happens is their wrist will bend and they'll start to cheat and they'll use other muscles. So their wrist will bend and they'll try to hold themselves up by bending their wrist. So you can see Colin easily can do that. Now bear hug, I have people come across like this and I'm going to push up on you. Don't let me push up on you. And that gets the lower border. In general, subscapularis tears more commonly occur at that top third to half. And the bear hug is very normal unless it's completely blown and retracted off. There's a lift-off test. I don't use this a lot. It's kind of hard. It's where people get back in here and try to push off their back. I don't find that to be as helpful. And some patients are so stiff they can't even get back there to begin with. Now we're going to move on to some labral tests. So the cross-body adduction or O'Brien's test, you come across your body about 30 degrees, so you're elevated 90, about 30 degrees, thumb down. So this puts your biceps on tension as it inserts on the superior part of the labrum, the supraglenoid tubercle. So I'll have Colin resist me here. And if that's painful in that position, then you go thumb up. So as you go thumb up, that biceps will relax. If this doesn't hurt anymore, that's a positive test. And we see that a lot in throwers who have slap tears or superior labral and biceps pathology. That test tends to be pretty painful. Speeds is straight up in front of you in a supinated position here. Don't let me push down on you. That can bother people that have some biceps fraying, although somewhat non-specific. You can imagine if you have a cuff tear, this is going to bother you as well. So I do this, but I don't put a lot of stock in it when people have big cuff tears too. Another test that's specific for biceps is called Yergeson. So I have people go in a pronated position. I say, I'm going to shake your hand. I want you to supinate up against me. And you see if that hurts. You can see you're firing your biceps, a powerful supinator. Unless the biceps is really in bad shape, I find that oftentimes is not positive. And then for AC joint, just simply coming across and add cross-body adduction, so just simply coming across really pinches your acromion and your clavicle together. That can be positive in people with a lot of osteolysis of their distal clavicle or arthritis of their AC joint. We are going to move on to the instability exam. Before we do this, I wanted to touch on one point in terms of the range of motion exam that's important. A lot of you guys will see in the clinic a diagnosis called adhesive capsulitis or a frozen shoulder. And what's important on exam to diagnose that is people will be very stiff actively. So you have them raise their arm and do this external rotation, internal rotation, all the things we just showed you themselves, and they'll be stiff with that. Then you try to passively do that. If you can move them much more, then they're more pain-mediated stiffness, which is not adhesive capsulitis. If you passively cannot move them any more than they can actively, that's how you diagnose a frozen shoulder. Largely a clinical diagnosis, but it's both active and passive motion, so pay attention to it when you see it. Now for the instability exam, I find this best and easiest to do lying down. One of the reasons being is just simply being in the supine position on a table will stabilize your scapula. The scapula gives you about a third of your motion of the shoulder. So having it stabilized here is really helpful to when you're going through your labral test for instability, with anterior instability by far being the most common. When you're evaluating a patient with shoulder instability, one of the exam metrics to go through is what's called a Baton score. As best we have a measure of generalized hypermobility. So there's 9 points to it. Can you bend your thumb and touch your thumb to your hand? Bring your pinky up past 90, put hands flat on the floor, hyperextend elbows and hyperextend knees. So something, if I have a patient with instability, we get a Baton score on everybody. And it's not perfect, but it's somewhat of a quick and dirty way of understanding who might be a hypermobile patient with secondary instability from a trauma, or who might just be a multi-directional instability patient to begin with. So on examination of the shoulder for instability, one of the things you can see in the hypermobile patient, if you pull down, Colin's not going to have one, but you can see what's called a sulcus sign, and it's pretty pronounced between the edge of your acromion and where the lateral aspect of the humerus, where the greater tuberosity is. You'll actually see a little sulcus here. You have to be pretty hypermobile and lax to see that, but something that we check for in those patients. Now for anterior instability, the most common test we do is an anterior apprehension test. So we'll stabilize his shoulder on the table here. I'm actually going to stand up, and we'll bring him up, abduction into 90, stabilize his arm, and then we slowly start externally rotating. And you tell the patient, tell me when you are nervous or uncomfortable. And usually when you get close to 90, if they've dislocated before, this is uncomfortable for them. So that's apprehension. And I always note at what degree of external rotation a patient's uncomfortable. Sometimes I see people where it's here. That means they're very unstable. They won't let you go anymore. And then if you're here and they're like, well, I'm unstable, you can push back. We call that a relocation, and you ask them, do you feel better? And most of the time they'll say yes, because you're translating the humeral head posteriorly, so you're reducing it, which takes some of that apprehension away. Another test that's helpful for a Hagel lesion, a humeral avulsion of the glenohumeral ligament, is called the Gauger test. So you stabilize the scapula with one hand, and then you abduct them. And if you can abduct them above 105 degrees, that's a positive Gauger sign. So you always check side to side. Colin's at about 95. This puts your inferior glenohumeral ligament on extreme tension. So when people have a Hagel or an avulsion of that, they can, I've had people where you can bring them up to 110, 120. They just keep going because there's no restraint on the inferior part of the humeral neck. For posterior instability, I usually do a jerk testing. So you come across like this, posterior force, and then you start to come out to the side here, and you'll feel a click as the head, which is subluxed out the back, kind of self-reduces as you do that. That's a sign of posterior instability. And the final one is pulling some translation on the arm, and then just doing a load and shift to the back and to the front. And in someone that's lax or is dislocated before, you can usually get quite a bit of translation. And again, comparing side to side is incredibly helpful to know what the normal for that patient is if their other shoulder is uninjured. I like to end my exam by doing a thorough neurovascular exam. So of the upper extremity, there are peripheral nerves and then there's central nerve roots. I think it's important to check both. I start just by getting a radial pulse, which everyone will have unless they have a fistula. After that, I check the peripheral nerves first. So the axillary nerve, you can have sensation up on the side here. That's also T5, or C5, excuse me, in terms of your cervical nerve roots. And then your deltoid is an anterior, middle, and posterior third. So I have patients make a fist, and I have them bring their elbow backwards, punch forward, and then kind of chicken wing out to the side. So that's testing that your deltoid, and that's innervated by your axillary nerve. So that's that. Musculocutaneous nerve supplies your biceps. So we'll just have Colin come up against resistance here as musculocutaneous nerve is working great. Your radial nerve, I'll give you both wrist extension and thumb extension. So you bring your thumb up, Colin, hold up there, don't let me push down on you. That's testing radial nerve. Grip strength would be your intrinsics or your ulnar nerve. And you can also, in people that have long-standing ulnar neuropathy, typically cubital tunnel at the elbow, you can look and they can start to get some hypothenar eminence atrophy. It's pretty rare in a sports clinic, but something to pay attention to if you have more older patients that may have some central or peripheral nerve compression. But then you just have side-to-side grip strength. Give me a big squeeze here. Yeah, no problems at all. And then wrist flexion here. Yeah, no problem. And then in terms of the nerve roots, we talked about C5. C6 is your thumb, C7 long finger, C8 here, and then T1's kind of in the axilla region. So something that's best practice to check on all patients, particularly those that may have some underlying peripheral or central nerve compression. All right, thank you guys for taking the time to watch our video. We hope to see you on the orthopedic service, preferably sports, in the near future.